today, and I wanted to give you just quick notice of some things that are coming up. We have, let's say, got it. There we go. We have, after today, we have 2 more talks coming up. Dr. Erin Vogel will be talking about orangutans, and she is going to be speaking here on April 12th. And then Rebecca Sleater, she is a career talk, and she will be talking about what it's like to be a registered environmental health specialist. She will be on Zoom only on April 13th. So we encourage you to attend those also. Thank you for being here today. We're very excited to have our speaker today. And let me
put my,
thanks. Let me introduce her for you. Dr. Christina Williams is an assistant professor of obstetrics and gynecology at Cooper Medical School of Rowan University, and she practices general obstetrics and gynecology at Cooper University Hospital in Camden, New Jersey. She grew up here in South Jersey, then attended Spelman College, where she earned her bachelor's in chemistry and graduated summa cum laude, and she earned her MD at Harvard Medical School. During medical school, she was an active member of the Student National Medical Association and the Women of Color in Medicine and Dentistry group, where she served as president and director, respectively, in her second year of medical school. Dr. Williams completed her residency of obstetrics and gynecology at Pennsylvania Hospital in Philadelphia. She has practiced as faculty in the Department of Obstetrics and Gynecology at Cooper for 4 years. She is currently the clerkship director for obstetrics and gynecology and sits as the chair for the Positive Learning Environment Committee at CMSRU. She enjoys teaching and mentoring and has participated in several panels focused on diversity in medicine. She is a proponent of educating minority communities on health, and her interests include racial disparities in obstetrics and gynecology, medical education, patient-provider interactions, and the health of women in minority communities. Welcome, Dr. Williams.
Thank you. Thank you very much. Well, I'm very excited to be here. I do want to get a quick poll of the room. I've actually never given this talk to non-physicians, and so I apologize if I use medical terms without even realizing it, but I'm going to try to explain the medical terms that I do use. So it seems like most of you all here are college students, correct? Any graduate students? Okay. Faculty? Excellent, wonderful. Well, welcome everyone. I also want to get a poll of kind of baseline knowledge of this topic. So how many of you all are familiar with eugenics? Okay, and how many of you all are familiar with the story of J. Marion Sims and Betsy Anarcha and Lucy? Okay, let's go. Wonderful. Okay, so we're going to touch on some of those topics today. Like I said, if at any point I say something that is not being received well, like you can't understand what I'm talking about because it's, physician level, please do let me know. But today we're going to be talking about race in American reproductive and gynecologic practices, and we're going to be focusing on a historical perspective, past to present. And I will say that many of these topics can be somewhat controversial and somewhat disturbing, but it is our history. And so, I don't shy away from talking about the things that matter. I do have a few disclosures, none financial, but the first is I identify as a learner and an educator. So I don't necessarily do research on this topic. Most of the stuff presented here are not primarily my own thoughts and opinions. Most of it comes from texts and documents and online resources. And so when I was preparing this, it actually, the birth of this presentation came during COVID, right after the George Floyd murder. I was talking to my department chair, and she was really interested in educating the department on the racial history of gynecologic practices. And we were talking about it, and I said, well, I'm reading this book called Medical Bondage, which I'll give you guys that resource. And, it's very interesting, the history of how gynecology was born and the practices that were performed on enslaved women. And she said, well, why don't you give a grand rounds on it? And I was like, okay. And then I spent countless hours, going through different resources and preparing this talk. And so again, this is an interest of mine, but I learned a lot when I was preparing it. And now I'm spreading the knowledge that I've learned through my own research. I always like to say I identify as a Black woman, but I'm not an expert on the issues that plague the Black community. I think that this kind of stems from the, being in a classroom and a topic about African Americans come up, and then the professor looks at you because you are an African American, right? But we know that Black people are not a monolith, right? So everyone has their own thoughts, opinions. We're a heterogeneous population, and so again, I did try to make this presentation non-biased, and it does focus mainly on Black women, and not to discredit other minority populations in which were treated poorly throughout history. But we will focus mainly on that population. But again, I do not think of myself as somebody who's the speaker for the Black community. And then my last disclosure, so online there is a test called the implicit association test. And this test was created by some faculty at Harvard. And basically it's a public resource where anyone can go and take the test. Now, what it measures is implicit bias, right? So they have various tests. There is a test for Black versus white. There is a test for obese versus thin, young versus old. And basically what it does is it helps you to identify your own biases. So what do you have a preference for over the other, right? And so I took the implicit association test a little while ago, and it showed that I have a moderate automatic preference for Black people over white people. Now, I don't say this as a good thing. I don't say it as a bad thing. I say it as it is, right? Because I think a lot of times what we do is we shy away from our own bias. And we as people cannot eliminate bias. We are people, we're human beings. There will always be bias based on how we were raised, based on the communities in which we function. But the way to minimize bias, especially in medical practice, is to recognize it. Recognizing your own bias helps to minimize it. And so as I am sharing my biases, I encourage you to figure out what your biases are and really think about them and think about how they cause you to function in everyday life. All right, so this is the overview of the presentation. We're going to start with some introduction and objectives. We're going to talk about the antebellum or slavery era. We're going to talk about the eugenics movement. We'll touch a little bit on modern day racism and implicit bias in medicine, and then we'll end with conclusions. So this is the problem, okay? The problem is Black women experience the medical system differently than white women, okay? This has been documented over and over again. Black women are more likely to report unmet medical need and higher rates of poverty, lack of insurance, and unemployment. So there was a study done in, I believe, 2017, where we looked at the quality measures in the United States. So quality measures, colon cancer screening, access to care, ability to see specialists, vaccinations. In 35% of the reported quality measures, Black women receive worse quality of care. And there are known differences in various outcomes. And that is due primarily to the racial disparities that we see in healthcare. Sorry. And then probably the biggest one and the most publicized one is maternal mortality. So we have a problem in the US. Maternal mortality is increasing over time for all races. We did have a spike in 2020 and 2021, probably due to the COVID pandemic. But when we actually look at maternal mortality by race, we know that Black women have at least a 2 to 3 times higher mortality rate when compared to white women. And we can see here, so this graph on the side here, on the x-axis we have time, on the y-axis we have maternal mortality, which is maternal deaths per 100,000. And you see here, this graph is from the 1930s up until 2007. And you can see all the way on the right side there, you see that in the 1930s, maternal mortality was high for everyone. So the red indicates maternal mortality for Black women. The green indicates maternal mortality for white women. And the gray is the ratio. So again, in the 1930s, it was high for everyone. As modern medicine became better, we started to use proper surgical technique and things of that nature, the maternal mortality rate has come down. But you can see that the actual ratio of the maternal mortality rate with Black versus white women has kind of stayed steady in that 2 to 3 range. And so why is this? What is the cause, right? We know actually now that race is non-biologic, right? So race is a social construct. If I took a African-American woman and placed her next to a white woman, then she probably has theoretically similar genetic makeup to those two than she has to another African-American woman. So it's not like because of race, genetics are, greatly different. So why are we seeing this difference? And so the objective of this lecture is to understand how history has shaped practice regarding reproductive and gynecologic care of Black women in America. So these are my primary resources, and I just wanted to kind of point these out in the very beginning. Most of the ideals and information about history come from these 3 texts. The first text that I read and that I talked about a little bit in the beginning of the lecture is Medical Bondage, Race, Gender, and the Origins of American Gynecology. It was written by Deidre Cooper Owen. She is a historian, an anthropologist, and she writes a really, really great text that documents the history that I will really only touch the surface on today. So if you want more information about the actual history, I really highly recommend reading her book. It's very unbiased and it really just kind of lays it out very, very nicely. The second text is the text by Dorothy Roberts, Killing the Black Body. Dorothy Roberts is a law professor who currently works at Penn. And she writes it's probably one of the first texts of its kind about how the government has really imposed themselves on the reproduction of Black women. And again, a lot of the information in this presentation comes from some of her thoughts. And last is Caste by Isabel Wilkerson, which I'm actually currently reading now. And I think that this text really kind of almost changed my perspective a little bit about racism in America. And she argues that race is not the issue. The issue is that we're in this like hidden caste system, right? In India, caste it is what it is. It's well known. It's present, ever present, right? And so you can kind of fight it more so because it's in your face. But in America, we've always operated under somewhat of a caste system, but we just never really realized it, or nobody ever kind of points that out. And so that's kind of how racism has been perpetuated throughout history. So I really highly recommend these 3 texts. All right, so let's talk a little bit about the antebellum era. So the main ideal that was ever present in this time period that kind of led to the stereotypes that we know now is surrounding scientific racism. And scientific is in quotes because it's really not scientific, right? It's not, we think of science, something that's scientific as something to be true fact. And these things were not, but they were published under the ideals of science. And so, people thought them to be true during that time period. So one is that race is biologic and determine one's behavior, right? So some people wrote that, depending on what culture you came from or what race you came from, you were smart or feeble-minded, you were a criminal, it just depended on what race, the race that we as Americans created, depended on, how you acted and what your social characteristics were, and your children are going to follow suit, right? So the children born to you, if you're a criminal, your children are going to be criminals, of course, right? So it also determines superiority and inferiority. So someone of one race is superior than in compared to somebody of another race. And these, when I talk about these ideals, these were not just things that one person said one time. Are you guys familiar with the New England Journal of Medicine? Yeah, right. Pretty reputable source. So in this time, these things were published in journals that were as reputable during that time as the New England Journal of Medicine is during this time. Blacks are impervious to pain. So, this kind of justified how enslaved people were treated, because they don't experience pain. You can treat them however you want, which honestly doesn't make sense when you hear somebody cry out because they're being, beaten or whooped and things like that. But again, this is the type of stuff that was published in the, medical journals of the time. Black bodies were vectors of disease, right? So what tended to happen in the times of slavery was, enslaved people would live in close quarters. They would be in the fields together, so if one person came down with a disease, everyone had it. They were actually forced to reproduce. So sexually transmitted infections were actually high among Black people as well. And so what happened is that everybody looked at enslaved people and said, oh, like they carry diseases. They all carry diseases. They're dirty, right? And so these ideals somewhat justified their treatment, right? So, you don't, as a person during that time period, it helps you to not feel guilty for how you're treating these people. These people are less than, right? It's kind of like, animals, right? How you would treat an animal compared to a human being, right? So, so these ideals justified those things. Another ideal was that Blackness was actually abnormal, that it was a skin condition, like a disease. And actually one of the founders of just general medicine talked about how Black skin was, leprosy, which is an autoimmune skin condition, and was trying to cure it, right? So giving people creams and acids and things like that to cure their Blackness, right? So, these ideals, again, perpetuated throughout time and led to some of the stereotypes and things like that that we now know today. So during the antebellum era, there were two main advantages of slavery that contributed to current ideals of reproduction and gynecology. The first one was the economic incentive regarding Black women's reproductive ability. So in 1662, the US passed laws that enabled chattel slavery. So what this meant was that any person born to an enslaved woman was automatically a slave and automatically owned by whoever owned the woman. And so, when we think about, again, when we kind of go back to like a caste system, right? Generally speaking, if you look at history in India and things like that, usually your caste is that of your father. In the US, it was that of your mother. This was an advantage for slave owners because they could even impregnate their slaves and then use the offspring for their own benefit, for their own financial incentive. In 1808, the US banned importation of African-born people. So this made it even more common or better for an enslaved woman to have reproductive ability, because now how are you going to make more slaves? You can't go get them. The only thing that you can do is have your enslaved women reproduce more. And then in the 1820s, so just to kind of demonstrate like how enslaved women were thought of as property, in the 1820s, there popped up a bunch of different slave warranty cases. So basically, if I were to sell a slave or an enslaved woman and the owner found her to be defective, unable to reproduce, having a disease, things like that, they could actually sue who sold them the enslaved person. And so again, it was all about financial incentive. And this is a quote that was in Killing the Black Body from a slave owner, where he writes, I'm assuming it's a he, I own a woman who cost me $400 when a girl in 1827. Admit she made me nothing, only worth her victuals and clothing. Now she has 3 children worth over 3,000, right? So she herself is not really worth much, but her offspring are worth much more. I would not this night touch 700 for her. Her oldest boy is worth $1,250 cash and I can get it. Okay. So we talk a lot about in obstetrics and gynecology as well, we talk about the maternal fetal conflict, right? So how do we protect mom's rights while also, what kind of rights does a fetus have, right? So this is something that is ever present in today's culture as well. But in the antebellum era, the maternal fetal conflict was, how do we protect this offspring while still treating this woman like a slave? When there are stories of when women would undergo whoopings, they would actually dig a hole in the ground. They would place the woman face down in the ground so that her belly was protected, and then they would whip her in that position. There are various cases, but one of the biggest cases or most well-known cases is Celia versus Missouri. Celia was an enslaved woman. She was bought by her owner when she was 14 years old. From the time she was 14 years old, she was raped by her owner. She had 2 children who were her owner's children. And one night, her owner came to her cabin, tried to rape her, and she killed him. And she eventually, first she burned the body, tried to hide it, things like that. She eventually admitted to the murder, which sparked a really big criminal case. Now she had no chance in this criminal case, right? They, selected a jury, they had a judge, they had all those things. So they gave her a trial, but she really had no chance. But during the trial, she was pregnant. They sentenced her to hanging, and they basically planned her execution date for after she were to deliver the baby, right? Because we don't want to lose the offspring. We don't want to, this enslaved child, that will be enslaved child, belongs to somebody, belongs to a slave owner. So we don't want to execute her before she delivers. She did deliver a stillbirth, and then she was executed thereafter. And by the way, a lot of times women were blamed for birthing stillbirth babies, right? So how do you blame a woman when you're keeping them out of the fields, dehydrated, making them work, all of these things that obviously are not good for pregnancy, and then blame that woman for the stillbirth of their baby. Women were often given incentives for lighter duty while they were pregnant. Sometimes they were enabled to work in the field. This also encouraged them to want to become pregnant, because it's like, okay, pregnant, maybe I won't have to work in the field as often, maybe I'll get a little lighter duty, things of that nature. And again, enslaved women were blamed for some of their stillbirth and fetal death. All right, so another advantage of slavery during this time period was that slavery allowed for rapid development of medicine, mainly because enslaved women or Black women were used for experimentation. They experienced during this time period a disproportional number of gynecologic surgeries. Which brings me to J. Marion Sims, with which many of you said that you were familiar with him, right? So J. Marion Sims is what we know as the father of American gynecology, right? So he started off, came from, very, just meager living, wasn't rich or anything of that nature. His father actually didn't want him to go into medicine because in that time period, a career in medicine was, not really thought of as like a very highly successful career. But he started practicing in Alabama, where he really just did general practice, and took care of all women, so poor, enslaved, white women who were slave owners. So he took care of all women. And he's credited with the first reliable repair of the obstetric fistula, which we'll talk about in a second. He's also a pioneer in evaluation and treatment of women with infertility. He coined the term vaginismus, and these are all like big things in the gynecologic world, right? For many, many years, he was like revered, father of American gynecology. He created one of the positions that we use to do gynecologic surgery, as well as one of the tools that we use to do gynecologic surgery as well, which to this day is still kind of like on our OR set. We still use the tool. So why is he controversial, right? So he, again, was a pioneer in obstetric fistula repair. So this is just like a quick little anatomy course, right? So I'll just point out here. So this here is going to be our uterus. The bladder sits kind of like right on top of the uterus. This is kind of like This view is the woman kind of standing this way. And so theoretically, the bladder, even though it looks under, is on top of the uterus. The vagina kind of courses from, the cervix all the way to the external portion. And then a fistula is a communication between the vagina and the bladder. So that's what a vesical fistula is. And if you can imagine, if you have this connection, urine comes out of your vagina. There's no sphincter for control. There's no way to hold it in. Urine, literally, anytime your bladder fills up, urine pours out of your vagina, right? Not something you would want, right? Not something you would want to live with. And so in that time period, obstetric fistula was very common because we didn't have things like C-section to prevent birth injury. Sometimes they would have to a woman would be in labor for 72, hours, 3 days. The baby just wouldn't come. They had a lot of obstruction issues. And what that does is it compresses the tissue and it can kill the tissue and cause a fistula. And so, these women would live with this fistula, really kind of poor hygiene, things like that. And so many surgeons were looking for a reliable fix to this. What would happen is they would put in stitches or they would burn the edges and it would just break down. So the women would never really have any relief from that. So when J. Marion Sims was practicing in Alabama, he knew about, fistulas and things like that. He wasn't really an obstetrician at that time, but he was called on another doctor to go see Anarcha. Anarcha was 17 years old, and she was in labor for 72 hours. They ended up needing to use forceps. So forceps are like these big metal things that you put around the baby's head and you pull the baby out. So they ended up doing that to deliver the baby. And she developed a vesicovaginal fistula. And her owner begged J. Marion Sims, I know you can do this. I know you can do. You're like the only real doctor in town. I know you can fix her. He said, no, it's impossible. Nobody can fix fistulas. Sometime later, the slave owner of Betsy called. Betsy was another enslaved woman, and she had a fistula. He said, no, can't do it. I'm sorry. Lucy came up a little while later. She was 18 years old, and she had a fistula from giving birth 2 months ago. And so these were kind of popping up everywhere. And the story goes that, J. Marion Sims was called to treat a white woman. He figured out a position to put her in order to treat her for something completely different. And from there, a spark or an idea came up. Oh, what if I put women in this position and use these different tools and we can fix their fistula? He said, you can lease me. So the slave owners leased him, Anarcha, Betsy, and Lucy. I'll take them onto, he had like a little hospital clinic. I'll take them onto my pretty much plantation. He was also a slave owner. And I'll try my best to fix them. And so he takes the 3 girls, and they live on the plantation. And over time, he operates them sometimes up to 20 times, right? And so the reason that J. Marion Sims was controversial is because, he basically somewhat used these women, right, in order for his own benefit to fix this fistula, right? He writes in 1854 in the New York Medical Gazette, I was fortunate in having 3 young, healthy colored girls given to me by their owners in Alabama. I agreeing to perform no operation without the full consent of the patients and never to perform any that would, in my judgment, jeopard life or produce greater mischief on the injured organs. The owners agreeing to let me keep them and at my own expense. So I was thoroughly convinced whether the affection could be cured or not. He says, I worked diligently for 3 years before I cured a single case, operating on these 3 upwards 40 times during that time period. One of them submitted to more than 20 operations, not only cheerfully, but with thanks. Now, all we have is documentation from J. Marion Sims. We don't have any, in fact, this picture that we see here, this is just a painting that was done to depict it. We don't have any pictures from them. We don't have any documentation. We don't have any of their words at all. This is just the story from J. Marion Sims' point of view. And so what are the controversial ideals within this scenario. One is the medical experimentation. Now, a lot of people will argue, that what he was doing was illegal. He did not have the enslaved woman's consent. And, what was the purpose? Like, was the purpose for his own benefit? Was the purpose for the benefit of, these 3 young women and others actually that he had that also were affected by fistula? And really, if we think about the time period, this was not uncommon practice. It was not uncommon practice to quote unquote experiment, what we think of as experiment on enslaved women. These afflictions affected many women, not just Black women, they affected white women too. And a lot of people wanted a cure for this. And do I believe that Lucy Anarcha and Betsy, gladly and happily, underwent these procedures? Well, no, we don't have their point of view. We don't have their side. I do believe, though, that as we discussed, this affliction can be very who would want to live with something like that, right? So I do believe that they probably also, wanted a cure. I don't know, though, if they were happily, participating in what was going on. Another ideal was the use of anesthesia. So J. Marion Sims is criticized a lot for not using anesthesia. Through his records, he says that he did give them opium, but he didn't give them any sedation necessarily. Well, a couple things with this is, one, anesthesia as we know it now is not really available in the time period that he began to do his procedures. Anesthesia did become more available, probably following about 6 to 8 months after he started, but it was very dangerous. It caused increased bleeding. You would basically give people anesthesia, they wouldn't wake up. It was dangerous. It was a new medication. The other thing is that, and this is something that only kind of like OBGYNs would know, inside the vagina, the innervation actually is not as much as it would if you were to cut your skin. Most women, especially, this thought comes from women who have lacerations after childbirth, right? So if you're an OBGYN, you know that when you repair the inside of the vagina, the woman usually doesn't feel that part. When you repair the skin, that's kind of where the woman feels pain and sharp and poking. So we don't really know how much pain these women were under, especially, one, after having had children. A lot of times the nerves there can, somewhat die a little bit, especially with repeated surgery. So, it's quite possible that they really didn't feel much when he was doing his experiments. And the last controversial idea, which I think is actually in my mind the biggest, is the fact that there was no credit for the enslaved women, right? So he had, in the beginning, when he first started, many medical interns, other white men were very excited about it. They're like, oh yeah, we can pioneer this, we can help. After the first year, many of them dropped out because they weren't being successful. And so really the assistants were the women. They probably, so Deidre Cooper Owens writes in her text, as Sims surgical nurses, they learned the fundamentals of gynecologic surgery from arguably the most successful gynecologists of the 19th century. It is no exaggeration to state that these enslaved women knew more about the repair of obstetrical fistula than most American doctors during the mid to late 1840s. If they were white men, they would be alongside J. Marion Sims on, various statues and things of that nature, right? So, I think that is kind of the biggest takeaway that I get from this is that, these women were not recognized until recently. We didn't know their names. We only knew the name of J. Marion Sims. And, J. Marion Sims was not necessarily unique in what he was doing in terms of medical experimentation. Many pioneers, quote unquote, had done the same. So John Peter, and I cannot pronounce that last name, it's French, was also working on the obstetrical fistula repair. He was a plastic surgeon. He was noted to have 3 main cases, one white woman, 2 Black women. And the white woman surgery was successful. The 2 Black women kept failing. And he in a medical journal wrote, he kind of blamed the Black women for their fistula failing because of their sexual activity, right? So mainly, we all know that, enslaved women did not have control over their own bodies. It was not their fault that they, had to repeatedly have intercourse with various people, right? So, so that was John Peter. Ephraim McDowell, he is the father of ovariotomy, meaning removal of an ovary. He was credited for doing the first successful procedure of removal of a big ovarian tumor. After he did this procedure, he couldn't really repeat it. He didn't know why. Like, that one was successful. The woman made it out alive and made it into her 70s. But afterward, he wanted to repeat it. So he went out and he found various women afflicted with the disorder, all of them enslaved women, to kind of practice and to refine the approach. And so anytime, so these are abdominal procedures, right? So you have to actually make an incision to get to the ovaries. And anytime he did these procedures, the women, it would be fatal, essentially. And then we have Francois Marie Prevost. I'm sorry if anyone speaks French, I do not. Who kind of pioneered cesarean section in Louisiana. So cesarean section was also a death sentence during this time period. And so he went to Louisiana. He found women, he practiced doing the C-section, and eventually he was successful, but he practiced all on enslaved women. So I would say that J. Marion Sims is not a unique person for what he did. It was what the time was. They were operating within what the time was. So these are the kind of final implications of the antebellum era. One is that reproductive politics in America involve racial politics. Reproduction of women used for social objectives, right? Financial objectives, and not necessarily for that of the benefit of the actual woman, in which, the reproductive rights are, modified or controlled. There's development of many stereotypes. So this is where the development of the stereotypes that, Black women are hypersexual come from. The stereotype that Black people don't experience pain as much as, others. So a lot of these stereotypes developed in this era. And then this is when distrust in medicine developed. I mean, really for all populations, if you were sick enough to go to a hospital, you probably weren't going to make it out of the hospital alive. So nobody wanted to go to the hospital. It was a death sentence. And so in that time period, nobody really trusted medicine in general. But Black women even more, right? There was somebody who was like going around looking for women who had ovarian masses to like practice operate on them. There's stories in some of the texts that the women, like African Americans, would hide from this physician because they didn't want to be found so that they would be practiced on. And then the precedent that there would always be somewhat of a lack of recognition of women's bodies that were used, right? We think about Henrietta Lacks as well, just not getting that credit that is due. All right, so let's move on to the eugenics movement. So eugenics was a term that was coined by Francis Galton, meaning good in birth. And really it was to express the science of improving stock by giving the more suitable races or strains of blood a better chance of prevailing speedily over less suitable than they otherwise would have. Many historians call this essentially a pseudoscience because it's rooted in genetics, which we know genetics is true, but it takes into account social characteristics that we know are not necessarily inherited or genetic. The first published text was published in 1911 by Charles Davenport, and he writes a book about how eugenics is so great and how we need it. We need it to better our population. He writes that what eugenics is the science of improving the human race by better breeding, or as Sir Francis Galton expressed it, the science which deals with all influence that improve the inborn qualities of race. And he calls for a need for eugenics. He says, it is our approach to our intelligence that we as people proud in other respects of control of nature should have to support about 500,000 insane, feeble-minded, epileptic, blind, and deaf, 80,000 prisoners and 100,000 paupers at a cost of over $100 million per year. And he goes on to say at the end, but we have become so used to crime, disease, and degeneracy that we take them as necessary evils, that they were so in the world's ignorance is granted, that they must remain so is denied. And so he's calling for this need of eugenics based on the fact that, we have criminals in our society. We have poor people in our society. And he's saying that, in order to rid the nation of these ailments, we need to breed better. We need to eliminate those who don't fit into our population. And how can we do that? So Sir Francis Galton was big on what we call as positive eugenics. And I quote positive because it's nothing positive about eugenics. But he basically encouraged or wanted to encourage procreation of the best stock. He basically wanted the high society to marry, to have children, to reproduce. This is also where the fear that, the people will, the white Aryan race will die off and, be taken over by other races. And so in order to prevent that, he kind of writes, natural selection takes too long. So natural selection is, not going to work in this instance. What we need to do is we need to oppose social programs. We need to not help those who need help so that they will die off, and that our kind of richer population will succeed. So that was the positive side of eugenics, right? So the negative side was really just kind of, we're not going to allow those who we don't want to have children to reproduce. And through that was sterilization. So in 1907, the first involuntary sterilization bill was created, and it mainly affected male prisoners. By 1939, more than 30 states enacted these laws. And what I like to point out about this is that this was not some radical group saying, oh, we need sterilization, we need to do this. This is our US government who was supporting these laws. This is Theodore Roosevelt, our president of the United States, who are signing off on these bills. Okay, so this is not some just like, oh, this is just like a radical group on the side and they're crazy and, we can just kind of like push them to the side, right? This is our US government. One of the biggest Supreme Court cases was the case of Carrie Buck versus John Bell. John Bell was the physician in an institution in which Carrie Buck lived with her mother. It was an institution for epileptics. And Carrie actually was raped in the institution. Through the rape, she became pregnant and she had a child. The physician in who was over the institution argued that Carrie should be sterilized because her mom is feeble-minded, she's feeble-minded, and her child will be feeble-minded. And we don't need any more feeble-minded people in this world, right? And the Supreme Court ruled to uphold involuntary sterilization of Carrie Buck, citing in their case that 3 generations of imbeciles are enough. This is our Supreme Court of the United States. This brings me to Margaret Sanger, who I list here as a controversial figure. Margaret Sanger, for those of you who know her, is actually revered in the gynecologic world for coining the term birth control. She's the founder of Planned Parenthood, and she fought for women's reproductive rights and access to birth control. She wrote in 1914 that enforced motherhood was the most complete denial of a woman's right to life and liberty. So why is she controversial? Well, Margaret Sanger actually aligned with the Eugenics Movement. At the time, there was this push for positive eugenics, right? We don't want women that we want to reproduce to not be able to get pregnant, right? We don't want them to use birth control. Being a mother is, what you're here for. What these women are here for is being a mother. We want them to continue to reproduce, right? And so Margaret felt very, very strongly that it was a woman's choice, which she's not incorrect about. And so she pushed birth control, and she argued that birth control served the nation's interests. The way she did that was saying, oh, we have this whole population of people who we don't want to reproduce. We can use birth control for them. We can, put it in these communities. Like, look at it, it's great. So it's basically trying to convince the government and just the general population that birth control was good. In doing so, again, aligned with eugenicists. And so a lot of people argue like, oh, and you can see if you Google Margaret Sanger, you'll see kind of some opinion pieces popped up. Margaret Sanger's a racist, blah, blah, blah. Right. And, was she a racist? I don't know. I didn't know Margaret Sanger. None of us in the room knew her. I can't argue and say that she was. But what she did do is she gave credence to a movement that was essentially responsible for Nazi Germany. Right. So Nazi Germany looked at the US and they said, man, how is the US separating these cultures? Like, what are they doing? It's working so well. They had slaves for years. How can we separate our cultures like they're doing? So they literally looked at US policy and came up with the laws for Nazi Germany. And so, I think that at the time, Margaret Sanger probably didn't really understand what she was doing. And again, she was affected by the time and culture. But it just kind of makes you think back, like, what things are you trying to push forward and using, giving credence to things that probably shouldn't have it, right? So involuntary sterilization became more and more popular from the 1930s to the 1970s. It really had a lot of popularity among Southern populations. The thought was that any African American that lived in the South was feeble-minded. That was the big term that they liked to use during that time period. They weren't smart. Their children will be feeble-minded. And so if they were smart, they would move to the North. That's where all the smart African Americans lived. And so there were a bunch of eugenic boards that were really big in the South, specifically in North Carolina, and were responsible for monitoring the population around them and instituting laws and things of that nature to help move forward with involuntary sterilization. It was actually really big in California as well, mainly among the jailed population. And it was actually really big in other populations such as Hispanic and Native Americans. But while in California, African Americans were only 1% of the population, but they actually constituted 4% of the sterilization. So it was disproportionately affecting Black women. All right, I hope this works. Yes, okay. So this is a short video that I like to show. This is Elaine Riddick's story, who was a victim of eugenic sterilization in North Carolina. I don't know if volume works here. Great. Yeah, go ahead.
At the age of 13, I became pregnant. I was raped by a guy that lived across the street from me. He snatched me off the street and molested me and threatened my life and said if I ever told anyone that he would kill me. When they were delivering my son, they sterilized me at the same time. They had approached my grandma and said that if she wanted to continue to receive supplement, welfare, and food stamps, or at this time it was giving out these supplements, and she powdered pills, and said that if she did not sign the X, that they were going to stop her supplement. Mind you, my grandmother was illiterate. She had never, ever gone to school. She didn't understand what it was. So she signed the X, and they did this to me. I did not find out that they had sterilized me until I was 19 years old. I asked the state of North Carolina why they did this to me. They said that because I was feeble-minded, that I would not be able to take care of myself. I would not be able to tie my shoes, that I was just incompetent. The state of North Carolina also said that I had never performed perform the day's work in my life. They couldn't get me to do anything. But at the age of 13, I mean, should I not have been in school? They were saying that feeble-mindedness is hereditary. So they sterilized me so I would not produce my kind. Mind you, I am not illiterate, nor am I feeble-minded. I never went into high school, but yet I still acquired a college degree. They also justified that my child or my children would be people. My son is a semiconductor company. He has his own construction company. And he has his own real estate company. I mean, how can you think that your government allow these things to happen to a person? Like, you can't say nothing, you have no rights. To me, it took away all of my rights. They sterilized kids from, my understanding, my knowledge, as young as 8 years of age. I don't know what an 8-year-old can do that could cause them to do this to them. The only reason I can give myself is that because they're black.
So that is Elaine's story, and she was a victim of North Carolina sterilization under the direct orders from the Eugenics Board, where probably about 7,600 people were affected. And in 2012, they estimated that about 1,500, to 2,000 of the victims were actually still alive, right? This is relatively recent. This is not years and years and years ago. Oops. Okay. And then this brings me to the story of the Ralph sisters in 1973, toward the end of when involuntary sterilization was very prominent. So Minnie, Mary, Alice, Ralph, they lived in a governmental institution and they were mentally disabled. They were sterilized at the ages 12 and 14 because of it. And in 1974, there was actually a lawsuit that was filed on their behalf. They're actually still alive. They're actually still alive to this day. There was a lawsuit filed on behalf of them. And this lawsuit was won. And this is kind of when the government gave, there was national recognition about this problem. And then the government finally reversed their opinions and took control of, what was happening. And so the consequences of eugenic sterilization. So there was prohibitions placed on federal funding for sterilization. So women who have Medicaid or Medicare insurance, if they want to undergo a sterilization procedure, they have to sign a standard consent form. The consent form has to be signed 30 days prior to the procedure occurring. And the person who is being sterilized has to have had informed consent. They cannot be less than 21 years of age, and they cannot be mentally disabled. So they have to actually understand the informed consent themselves. And so this was put into place to stop involuntary sterilization or coercion towards sterilization for women. But the downside about this is that this only affects women who have a Medicaid or Medicare insurance. So women who have private insurance don't need to sign this consent form, and they can get a tubal ligation at any point in time if that's what they want. So, coercion can happen in those population of women, but also they have more control over when and what, over the procedure and when they, can undergo that procedure. So there's a little bit of a discrepancy in equitability and inequitable because of this consent form. And then distrust of the medical providers, right? So we hear now lots and lots of stories. It's all over social media. Why would I trust, these providers? these accounts, these stories that are relatively recent and have happened to people who are still alive today causes this kind of distrust that we see, which ultimately kind of inhibits medical care because, you know, I'd say that we as a population of physicians are really working hard toward trying to work on implicit bias. I don't think it can ever be eliminated, but you know, that is not something that patients are necessarily aware of or trust because of these things that have happened in the past. And so after sterilization, there was a lot of coercion that was going on in terms of using contraception. So the biggest thing was Norplant. Norplant is a implantable device. It is implanted, it's like a smaller rod about this big, and it's planted subdermally underneath the skin. So if you think about, like, it's comparable to, like, if you think about somebody's inserting a tracker, right? So it's kind of like, it's not a tracker, but well, some people have argued like they're trying to track me, but it's not a tracker, but it's a birth control, and it's implanted and it can stay in for up to, now we know, like 4 years. And so what would happen is that young women would be coerced into getting these contraceptives, but then nobody would take it out for them. So in essence, it's kind of somewhat sterilizing them, not permanently, but for the time being. So they were not able to get pregnant. There's also cases of women being ordered to get Norplant by a judge, right? So because they, you know, were on some sort of probation, and in order to, like, you know, get off easier or whatever, they had to get Norplant, right? So some coercion. In the Philadelphia Inquirer in 1990, there was this big, again, suggestion of creating an incentive to use Norplant among Black women to fight poverty. And they write in this text, now there are many ways to fight back, from better prenatal care to better schools, but it's very tough to undo the damage of being born into a dysfunctional family. This is in the Philadelphia Inquirer. All right, the subject makes us uncomfortable too, but we're made even more uncomfortable by the impoverishment of Black America and its effect on the nation's future. Think about it. So instead of better prenatal care and better schools, let's just make it so that these women can't reproduce. Right. And so the thing about contraception that I think we're realizing more and more now is that historically, for white women, it was a mode of liberty, right? But for Black women, it has been used for control and coercion. So let's talk a little bit, and I know that we're running low on time, so I'm going to try to get through this quickly, but implicit bias in medicine currently and what our current situation is. I'm going to actually skip this and go to here. So racial bias in pain treatment. So this is an article that was published in 2016. And basically what was done is medical students as well as resident physicians were surveyed, and they were giving a number of statements, some of them false, some of them true. But some of the statements read, you know, Blacks age more slowly than whites, Blacks' nerve endings are less sensitive than whites. And these were all white medical students and residents. And what they found was that actually 50% of this sample actually endorsed false beliefs. The biggest endorsement was that Black skin is thicker than whites. So medical students and residents believe this to be true. And those who did endorse these beliefs actually treated pain in just basically a scenario that they gave them. They rated pain as lower for Black patients, and they made less accurate treatment recommendations. And so this kind of just exemplifies like what we see actually in medicine about the treatment of pain, right? There are studies showing that, you know, when Black women go to the ED versus white women, they tend to get less treatment for their pain, you know, that white women do. This is this is basically some implicit bias that we've seen in the obstetric world. So in women who have had one prior C-section, we allow them to try for vaginal delivery. It's called a TOLAC, trial of labor after cesarean section. And the success that we think that you will have a successful vaginal delivery depends on a number of factors. And so there's this calculator that was published several years ago where you can input those factors and then come out with a percentile of whether or not you thought that the woman would be successful in having a vaginal delivery. And if it was below a certain number, you would say, don't try. And if it was, higher than a certain number, you'd say, okay, go for it, right? And so erroneously, race was placed into this calculator. And the reason that it was placed is because there is like literally one study that showed that African-American and Hispanic women had a lower success rate for vaginal delivery when they've had one C-section. But we know now that that's probably due to a number of things. Counseling that goes into it, the bias of like just looking at the patient, oh, you're not going to be successful, right? So there's a number of things that go into it, but this was placed into the calculator. And so if you place everything else being the same, this calculator, if you just kind of change the race, places this patient that we have here at a success rate of 53% if they're Caucasian, 37% or if they're Black or Hispanic. And so based on this calculator alone, they were telling me, this was basically published by a society, and they said, Dr. Williams, as an OB, you need to go in and counsel your Black patient that they don't have a high success rate until I can recommend a C-section, just based on the fact that they are Black, which we know is not biologic, it is a social construct. By the way, nowadays, now we don't use this calculator anymore, but this was relatively recent. Like this was like in 2018 when this calculator kind of became big and was being used very frequently. So implicit bias is definitely present in OBGYN. And we know, so we think about the different disparities that we see, and we think like, what is going on? Is it the counseling? Is it the treatments? Probably both. We know that Black women are 1 to 2 times more likely to undergo permanent sterilization than white women, and more likely to seek reversal, right? So they actually have a higher rate of undergoing it, but then at the end of the day, they come back to get it reversed, which you can do. It's a hard procedure, but you can do it, right? So why would they want it reversed if they wanted it in the first place, right? Maybe they didn't really want it in the first place. They're more likely to receive general anesthesia when undergoing C-section than white women. So the standard of care is to do regional anesthesia, where we just numb the woman from the waist down, but for whatever reason, Black women undergo general anesthesia more frequently. Black patients are less likely to receive treatment consistent with evidence-based guidelines, and have worse survival outcomes for some gynecologic cancers. So this is all validated evidence in the literature. And last but not least, when we look at, so there was a big study that was done in 2020, and basically they looked at hospital systems in Florida. And for whatever reason, Black newborns have a higher morbidity mortality rate than white newborns. And so what they did is they looked at the providers that were caring for those infants. And what they found, so in this chart, the red line is the baseline. This higher here is the kind of like morbidity mortality rate. So if we have a Black patient and Black physician, then we have a morbidity mortality rate that's lower than if we have a Black patient and white physician, which is all the way up here. So they correlated having this discordance of a Black patient having a white physician leading to worse outcomes. So to conclude, there are several things that are deeply rooted in history. So definitely the control of Black women's reproduction for social objectives. Again, so sometimes the objectives are we want women to reproduce all the time, slavery era, and sometimes the objective is we want them to stop reproducing, right? That's our eugenics movement, right? But it just all depends on what America wants at the time, right? And so that's kind of where the politics comes in. But why should a woman's body be governed by the US government? What is that about? Scientific racism and the stereotypes of the Black body, especially regarding Black women's bodies, that's also deeply rooted in history, starts with the Antebellum Era. And then these stories that we hear over and over again regarding medical providers' experimentation and coercion of the Black community by medical providers. Implicit bias definitely has an impact on outcomes for our Black patients. Again, how do we eliminate it? We probably can't, but We seek to minimize it. And we really can't change the past. So I think about these stories. I think about Margaret Sanger. I think about J. Marion Sims. I think about, the protests that have happened. And I think that those are legitimate. But I don't necessarily think that that is the answer. It's legitimate to be angry about what has occurred. It's legitimate to want recognition for Lucy and Narca and Betsy. It's legitimate. But I don't think that's necessarily going to achieve our objective of basically being treated equally in the medical system. Black women and white women, Hispanic women, all women treated equally. So we can't change the past, but we can understand how that past has shaped the future. And I leave you with this quote from Time Magazine. Margaret Sanger's misjudgments should cause us to wonder what parallel errors we are making now, and to question any tactics that fail to embody the ends we hope to achieve. That's it. These are my references.
All right, we have some time for questions. And if you're speaking from the audience, I would like to bring the mic over to you so that our Zoom audience can hear you also. So please raise your hand. I'll bring the mic up to you, and you can also answer any of the Zoom questions on there. Thank you.
It's not necessarily a question, but I just wanted to acknowledge, this is the 4th semester I've come into this talks, and I believe you're the second Black woman speaker that we had. And I really do appreciate you coming and the topic that you talked about. That's what I want to say. It really wasn't a question. I just want to say that.
I'm happy to be here.
Thank you. Anyone else?
Thank you, Dr. Williams. Your research has focused on the United States, but in your studies, have you found similar discrepancies elsewhere in the world? Is the United States an outlier, or is this a problem that plagues the whole planet?
So I guess it depends on what you're talking about. Are you talking mainly about reproduction, or? So in terms of reproduction, I think that the US is the worst, I would say. There is definitely instances of involuntary sterilization in other countries. But I think for a developed country, the US kind of has the worst reputation for it. There are other big what we call caste systems. So in India, there's a big caste system, and then Nazi Germany. And those are really probably the primary 3 examples of how, ingrained and intertwined that system is in just a population setting.
So I was wondering, in your day-to-day work, do you do any work with midwives or doulas in the community?
So I specifically do not work with midwives. So we actually have at the health system that I work at the notion that doulas are actually a part of the medical community. And so we welcome patients to bring, if they have a doula, to bring that doula with them. And for example, during the times of COVID, we didn't count that as their one visitor. We welcome the doula in as a part of the medical team, but we don't specifically, find doulas for patients or assign patients to doulas. I have worked with midwives in my days of a residency, which was very rewarding. I learned a lot from midwives. I think it's just a matter of how the practice is set up, medical, legal, all those different things kind of play into it. Thank you for your question.
What do you think about First Lady Tammy Murphy's task force to address maternal mortality in New Jersey? What do you think works about it? What's effective about it? And have you noticed any changes during your time in practice?
Yeah, thank you for your question. I can't say that I specifically am aware of what kind of pillars are on the task force. I think that in New Jersey in general, we're doing a lot to make sure that we are looking at the data, actually looking at it by race and things of that nature. I know that there's a big push at Cooper to do so, to actually examine our outcomes by race and not just overall. But if you are aware of what the pillars are of her task force, then I'm happy to like look at them and share with you, whatever my thoughts are on it. But I'm not familiar with it on the top of my head.
For your talk
course.
today. Follow-up question in regards to the data you provided as far as the skewed ratio of likelihood to, go into a cesarean versus vaginal based off of race. With that notion, what are your thoughts on the misconception of, okay, after a cesarean, you can then only have cesareans for following children? And your thoughts as far as how that then challenges or basically decreases the likelihood of a improved immune system of those children that are born cesarean versus vaginally, and how it then plays out, well, racially, because it's skewed.
Yeah, I mean, I think it depends. So it depends on the hospital system, because so I know that there's like a bigger misconception that you can't try for a vaginal delivery after C-section. And I think that comes from historically, a lot of providers were not comfortable with doing that because it does come with its own risks. And so if you go, especially in smaller communities, if you go to those hospital systems where there's not a lot of support for the obstetricians within the hospital, they generally will tell women that they cannot have a vaginal delivery, mainly because they can't support them safely through a vaginal delivery after having a cesarean section. And so I do think that that's an issue and it's a problem. I encourage all of my family members to seek care at an academic practice. I think that that is the safest if possible, just because, again, these community physicians, generally speaking, sometimes, I'm not speaking about all of them, but sometimes can be out of date with their general recommendations because they don't have to kind of like keep up with academic practice. And so, I know that at the health system I work in, we encourage all women to try for a vaginal delivery. And we don't use calculators. Like, it's just kind of like a standard practice to say, like, I think you should try for vaginal delivery. Here are the risks, and you can choose not to if you don't want to. But we're kind of trying to readjust those expectations and those misconceptions among various communities. But it's hard to do so on a grand level, especially when you hear stories about things going wrong. Because the one thing I always say to patients is that you are always going to hear stories of bad outcomes. People don't really talk about their good outcomes as commonly as they talk about their bad outcomes. And so try not to, do listen to things that you hear, but try not to kind of like take that in as that's going to be you. Because again, most people don't necessarily talk about their really, great outcomes. I don't know if that answers your question, hopefully a little bit. I think
we have a question from online. Anastasia asks, do different reproductive cancers plague Black women more because of the lack of treatment, in your opinion?
So, for example, cervical cancer. So cervical cancer is a highly preventable cancer. It tends to have higher rates in Black women due to, so the theory is that, there are, populations of Black women who don't seek care. So if you don't get a regular, pap smears when you're supposed to, that's when gynecologic cancer. But I mean, it also deals with communities, right? Like, what access do you have? It's not all about like, oh, I just didn't go to the doctor, right? What access do you have? And also, like, I kind of understand it when people don't want to go to the doctor because they've been treated poorly by doctors for so long, right? And so it's kind of about readjusting those expectations on a grander level, which I try to do, but it's really hard to do, especially when sometimes you're kind of working against social media and things of that nature.
You're welcome to take a break at this point. You're welcome to head out.
If you have another class or you just want to, there's pizza that came quite late. So please help yourself on the way out, or just help yourself while you're in here. But Dr. Williams is happy to stick around and answer some more questions. So if you'd still like to ask some questions, I'll bring you the mic.
Hi, thank you for your talk. I saw you presented data for disproportionate use of anesthesia for Black women. for cesarean section, but have you seen any data about use of epidurals, like Black women being denied the use of epidurals based on the incorrect perceptions about Black women in pain?
Yeah, I haven't seen any direct data correlating to that. But I definitely, I mean, most of the data surrounds like treatment in the emergency department where, you know, you'll come in for an issue and either the time to getting pain medications or getting pain medications at all differs from, you know, white women.
Thank you for the eye-opening talk. It was very interesting. I just wanted to know what made you want to get your MD in this field specifically?
Yeah, so when I entered medical school, I didn't actually know what I was going to do. And half of the reason why I entered medical school is because essentially my mom was like, you should be a doctor. And I was like, okay. She's like, yeah, you're good at math and science. You should be a doctor. And I was like, oh yeah, that seems reasonable. So I go to medical school. And in the first 2 years, it's mostly classwork, lectures, things of that nature. And then the third year is when you actually do clinical rotations. And so when doing the clinical rotations, I found that like working in the OBGYN field was just like so much fun. You get to deliver babies, you get to do surgeries, you get to, you know, care for women, like primary care. So it's a mixture of all different things. And like really, I come from a big family of women. And so like as I kind of progressed through medical school, I had a lot of my friends and family asking me questions and, you know, things of that nature. And I just like loved being able to advise and help my family members as well. And so all that combined, I was like, yeah, I think OBGYN is for me. I mean, I think that the best, like the number one best thing about being an OBGYN is that I got to deliver my best friend's baby. Yeah, that's like my, like if I had to pinpoint one thing, that's like my favorite thing.
Hi, thank you for your talk. I appreciate it. And I had a question. You had mentioned that birth control for white women is more so liberating. And maybe it's just the algorithm, but as far as like what's it called? Voluntary, not I won't say voluntary, but wanting to get your tubes tied, wanting to have a hysterectomy. I see that like a more common issue in white women where they're denied and they've had their husband's approval and all this. Do you think that's more of like a eugenics thing? Like kind of like eugenics, but not eugenics, like kind of like pseudo eugenics? Like we're not gonna say it's eugenics, but it is. Just in your opinion.
Kind of, right? So it kind of goes back to that kind of like positive eugenics that we talked about in the beginning, where it's like, you know, you want white women to continue to reproduce and you don't want Black women to reproduce type of thing. So I think it actually potentially is rooted in that. That's a really good point. Thanks for pointing that out.
Hi, great talk. Do you think that we should limit the usage of scientific models that have been wrongly obtained from Black patients, such as Henrietta Lacks cells? And how do you think we can approach that?
So I absolutely do. I think that when I'm treating a patient, so when I was in medical school, they told us like, anytime you're treating a patient, you have to mention their race. Like when you're presenting the patient, you always mention the race, you have to take that into account. I have completely removed that from my practice. I do not put it in my notes. I try my best. I mean, obviously if somebody's sitting in front of you, like my implicit bias, I cannot say like, I'm not aware of their race, right? But I try my best not to think about that at all when I am suggesting medical procedures, things like that. And I, due to my own biases, I work hard to actually, you know, do my best to do that. So yeah.
Curious because I just want your opinion. If you are aware or heard of the class action suit for African-American women that have used chemical hair processing and straighteners and the increased incidence of breast cancer, ovarian cancer, and uterine cancer. Just curious, what are your thoughts on that? And if anything, is there a change in the field as far as how can we try to rehabilitate that as an existing issue? Because before there were, you know, just weird growths that were just accepted norms of, oh, it's very prone in this background, like fibroids, uterine fibroids. So I'm just curious, like, what are your thoughts on that?
Yeah, I will say that I haven't myself looked directly at that data. And we always have to be a little wary about association data, because basically what they do, is just take a bunch of different things and they put it into this huge system and like something pops up. But I don't necessarily not believe it. I don't discredit it. I mean, I think that there definitely are higher instances of these things among Black women. For example, when we think about uterine cancer, type 2 uterine cancer actually has a higher incidence among Black women than it does white women, and it's the more aggressive form. So if we know that race isn't necessarily biologic, why are we seeing higher incidences of these things? Could it be, cultural, what we eat, what we do, environmental factors, that's contributing to those things? I think definitely yes is the answer. I think more data needs to come out on that in general, but yeah, I mean, I always encourage women. For example, I have a lot of women in my practice that have fibroids, very common. And I actually encourage women to discuss, like some women have gone to like natural homeopathic, route, changing their diet, things like that. I mean, I think that all of those things can contribute to treating a disorder. I mean, I would say that I'm not the type of person that's going to say like only do natural remedies, but I think natural remedies in combination with like the medical therapies that we have available, definitely is something that I would recommend. Hopefully that answers your question a little bit. Yeah, go ahead.
Yeah, that's good. I want to thank you for your talk. It was really very enlightening, very interesting. I'm curious, you mentioned, research going forward about, investigating some of these issues with regard to race, and there's been a kind of a real shift that started over the last few years, even in the U.S. Census, to recognizing more self-identification as multiracial, multi-ethnic, and what do you see in terms of the potential effects currently and in the future in terms of trying to figure out what's driving different medical issues when you get more complicated in the data?
I think that we're going to lean more towards actual genetics. So actually like checking like what the genes are and do you have those genes, as opposed to splitting people by race, because that's, like you said, is becoming more and more difficult and probably isn't even really worthwhile. Now, I will say that I do think that there was probably a little bit of natural selection done, during the slavery period, just because it was more of like you were in a survival mode during that time period. And so there probably is a little bit of natural selection among that population, but the Black population is even more heterogeneous now, where there are people from all over the world who identify as Black who come here. So again, I think that we're actually doing a disservice to ourselves when we split things up by race when we look at data. Exactly. Yeah.
To what extent are conversations about these kind of inequities and disparities and outcomes part of standard medical school curricula? And has that changed significantly, or are we making progress there? And I guess then the follow-up question, which is unfortunately not entirely facetious, how soon does that get then banned in Florida medical schools? I mean, it's like, because I feel like some of this, it's like you make progress in some areas and back. So I don't know.
Yeah, well, I will say that. So I did medical school from 2010 to 2014. And I would say that when I learned about race again, I was told, oh, these diseases affect the Black population more. You can't use medications. These certain medications are better for this race versus the other. And, there was so they were, in a sense, they're trying to say like, okay, these are the things you have to be aware of in order to decrease these health disparities. But I think that the viewpoint has changed a lot more nowadays, wherein, we're learning that like we actually should pay attention to race less. So when I was in medical school 10 years ago, it was, yes, focus on race. And now it's like less so like, here's how you remove like race from your practice. So I definitely think over that 10 years, there's been a lot of change. There's been a lot of focus in education and medical education on these issues. But I would still say that we could do better. And, you know, I think it almost depends on the faculty and the school. And sometimes the students, because sometimes the students come up and say like, oh, we need more of this, more of that. But so in Florida, I would argue to say there's probably not as much education as there is at our medical school here in New Jersey. I don't know that to be a fact, but I really do think it depends on like the area that you're in and like the influences from the top. So.
Thank you so much. Unfortunately, we have a class coming in right now. I know a number of us still have a lot of questions that we want to ask. So I appreciate you being here so much. Thank you very much. And please, thank you, Dr. Williams, again. Wonderful. Thank you so much.
Steve, I'm department head. Thank you.